Uh, Hi guys, a very good evening. So I know that you're going through a rough patch of your life, but then this roller coaster is not going to be permanent. Pain is never permanent, and you are anyway much more stronger than the pain component. So rise and shine and participate in this question and answer session that we'll be conducting. We'll be doing multiple MCQs today, which would be from the various domains from general medicine. And my objective would be to help you get to your eyes to the correct answer. I think just give me a quick thumbs up with respect to the audio and the visual part, and then we can get started for today. And let me just bring up the first question for today on the screen as well. Okay, hi Utkarsh, good to interact with you. I missed a couple of people in the chat, but then it's okay. I think I'll keep on interacting with you as we progress onwards in this discussion. Okay, so here we are, starting with the very first question. This is going to be for a AIDS positive patient. The objective of today's discussion is to keep it mixed bag and simulate the exam scenario. And as I say always, I got your back. So I just want you to relax and rise and shine and participate in this discussion. So cool. Okay, I had an answer there also because of this presentation that is present on the image. But okay, pyrimethamine sulfadoxine came up. Subarachnoid hemorrhage is coming up there. I'm getting albendazole with steroids as well. So let me just read this up, right? We have a AIDS positive patient. He's having a headache. There's monoparesis and multiple episodes of seizures. And then there is a contrast in our CT head, which is present in this particular case. So one, we are sure that this is a immunocompromised patient. Very good evening to everybody. Please keep the comments flowing with respect to whatever you think is the answer to this question. And you can also mention regarding the diagnosis of this patient as well. Okay, so majority of people have answered this as option number B, that is subarachnoid hemorrhage. Now, subarachnoid hemorrhage in a AIDS positive patient would be a little unlikely. Ho to sakta hai, I mean, a AIDS positive patient can also be having a berry aneurysm that can rupture. But then I think you are all aware that the star of death is a feature that you see with a non-contrast CT scan. And in this image, what I have shown before you is a contrast enhanced CT scan. And what you can see in this patient is presence of basal exudates. So please be clear that what we're discussing today as the first question for today is not the star of death. We are not talking about subarachnoid hemorrhage. Even the clinical history does not match with it. He doesn't talk about presence of a sudden onset headache, worst headache of my life, all those routine things that are given in a question with presence of nuchal rigidity. Rather, he has described monoparesis, that's a focal deficit. Plus, there is multiple episodes of seizures as well. And then you can pick up basal exudates on a contrast and a CT scan. I've said this in rapid revision multiple times, and I'll say it once again. Every time you're going to read about basal exudates on a contrast and a CT, your answer would always be thought of as tuberculous meningitis or AIDS positive patient with वैसे भी tuberculosis is a common opportunistic infection. In fact, in AIDS positive patients, what you are going to see is that pulmonary TB is going to be relatively less common. It's extra pulmonary TB that is more common. So one, the message is that obviously they can develop pulmonary TB, but then the chances of dissemination is also very high. And therefore, guys, since you can pick up the basal exudates, that's the contrast enhancement that is present. Plus, you can also see, I put an arrow for your convenience, that is the dilated temporal horns. ये जो black दिख रहा है, ये basically क्या है, ये evidence है कि there is a hydrocephalus developing in this patient. So there are two things that are going in favor of tubercular meningitis. One is obviously that the patient is immunocompromised. Plus we are seeing basal exudates and dilated temporal horns, which are suggestive of presence of a hydrocephalus. So everything fits the bill for TBM, and that nails the answer to this question as option number A. A couple of people mentioned this as pyrimethamine sulfadoxine. I agree to the fact that the patient who's having AIDS can be having cerebral toxoplasmosis as well. But then if it is cerebral toxoplasmosis as an answer, then it will be showing evidence of intracranial calcification. and that calcification will mostly be present in the area of the basal ganglia. So since in this particular question, I cannot see any evidence of intracranial calcification, basal ganglia involvement, so is unlikely is an answer. Neurocystis to nahi hoga yaar. I mean, that will show that very characteristic starry sky pattern. So I don't think so that you had any issues with this. And a lot of people initially fell in the trap and thought that this could be star of death of subrecurrent hemorrhage as well. So wo jo star of death hota hai yaar, that's gonna be a feature that we read with subrecurrent hemorrhage. Usme bhi blood in the sylvian fissure is present. प्लस द हिस्ट्री में कुछ क्लिनिकल पॉइंटर्स रहेंगे ना, तो एक बार क्विकली मुझे बता दो व्हाट इज द नंबर वन कॉज फॉर सबरेक्रेंट हेमरेज गाइस. The leading cause for development of subrecurrent hemorrhage. The answer to this question is going to be obviously tubercular meningitis, but then the leading cause, yes, multiple ring enhancement. Exactly. That's the point that I'm trying to say with respect to any patient who's having cerebral toxoplasmosis. So, yeah, it is trauma, then it rupture of berry aneurysm. Any other cause you can let me know quickly? Any other cause for subrecurrent hemorrhage that you can let me know quickly? Yeah, trauma is one of the leading ones. Perfect. Keep the comments going. So the question will always talk about worst headache of life, or the question will talk about thunderclap headache. So that's standard. I mean, that nobody will mess up with. There's going to be nuchal rigidity or meningeal irritation also described in the question. But along with this, yes, guys, anything else that you can comment with respect to hypertension contributing to subrecurrent hemorrhage would be less likely ना भाई. Hypertension के जो patients होते हैं उनमें तो most of the time it would be a intracerebral hemorrhage. No, it would be ICH, that is a intracerebral hemorrhage, so that is less likely. So hypertension causing subrecurrent hemorrhage, sir, उससे ज़्यादा common चीजें बोलो ना. Arteriovenous malformation. If you're having a AVM, then arteriovenous malformation can again contribute to development of this. Charcot boucher aneurysm is a miscellaneous fact, guys. वो तो charcot boucher aneurysm is a feature of hypertension, and I mean, agreed. If I was saying the word aneurysm, then I'll take that into consideration. Mycotic aneurysms are seen with subacute bacterial endocarditis or infective endocarditis. The organism responsible for that is Staph aureus. But anyway, what I wanted to bring to your attention, yes, polycystic kidneys, that's a good one. If a person is having autosomal dominant polycystic kidneys, then there could be arterial dolichoectasias. These arterial dolichoectasias can rupture, and therefore subrecurrent hemorrhage could be occurring. Yep, connective tissue disorder is another one. And then the most important thing is that there is going to be a non-contrast CT head. यही तो यार, तो कंसेप्ट आपको समझना है कि अगर सीटी हेड में ऐसा इमेज आ रहा है, अगर सीटी हेड में ये इमेज स्टार ऑफ डेथ आप आइडेंटिफाई कर लेते हो, लेकिन जो question that we are discussing today, the question that we're discussing today, that had a contrast enhanced CT scan, and that's gonna immediately change the entire ball game. I mean, that's the point that you got to pick up it, because you are having a limited time. So I thought I should mention it. And anyway, we're conducting a grand test again for all of you on Prep Ladder. So I'll be informing you regarding the dates for the same as well at the end of this video when we are planning to conduct that. Okay, Ji. So the first one that we are discussing at the moment is a contrast enhanced CT scan showing a basal exudates, and then more importantly, AIDS positive patients में extrapulmonary TB ज़्यादा common होती है. That helps us in diagnosis of this condition. So we can हाँ जी, ऐसे ही क्वेश्चन आते हैं डॉक्टर साहब जो देख के लगता है कि हम कर लेंगे, फिर थोड़ा सा गलत हो जाता है. आई मीन, इसकी लैंग्वेज पढ़ना था ना यार. यू हैड टू पिक अप लाइक यू नो द स्टैंडर्ड जो मैंने वर्ड्स बोले एसएएच के लिए, वो तो नहीं था ना प्रेजेंटेशन. तो कंसेप्ट यही है कि बेजल सिस्टम्स में ब्लड है या बेजल सिस्टम्स में पस है, दोनों डिफरेंशिएशन कैसे होगा, एक प्लेन सिटी पे दिख जाएगा और एक कॉन्ट्रास्ट एनहांस्ड सीटी स्कैन पे दिखेगा. दैट्स द मेन डिफरेंशिएटर दैट आई वांटेड टू ब्रिंग टू योर नोटिस. Okay, Ji. Moving to the next one, HIV positive patient. The lesions could not be scraped off using a toothbrush. So he says, which of the following is responsible for this? Yes. Exactly, Lion King. You are perfectly spot on. So what we are talking about again is a HIV positive patient. They love to ask about HIV positive patients in NEET PG and FMG exam. So the diagnosis of this patient would be a oral hairy leukoplakia. And we are all aware that this can be seen in, again, HIV positive patients, but it is not caused by HIV virus. Obviously, it would be caused by Epstein-Barr virus. So the correct answer for this one would be option number D. that is Epstein-Barr virus. We have HHV8, which is renamed as Kaposi herpes simplex virus, that is responsible for Kaposi. But then the main keyword in this question was that the lesion could not be scraped off using a toothbrush. So it's going to be mixed bag questions that you're going to get in the exam. You're going to get one, which is going to be like a twister. It might, like, in cricket, they say the ball that swings the other way. If you can relate to it, or the dusra wala ball, right? And similarly here, one is a straight one. The other one was a delivery that went the other way. So this is sorted. Let's look at the next one liner. This talks about the exhaled nitric oxide being used for diagnosis of which of the following conditions. And HIV prophylaxis, TLD, doctor, standard tenofovir, lamivudine, dolutegravir, the one that they teach you in PSM. There are a lot of protocols that I've discussed in my original videos from CMDT, but I think the one that holds the ground would be what the PSM teacher would have told you. Okay. Okay, no, it cannot be scraped. No, that is why. No, that is why in the question it is written cannot be scraped, using a toothbrush. Anyway, the diagnosis is not Kaposi sarcoma for this one. The diagnosis is leukoplakia. Okay. So we are talking about exhaled nitric oxide being used. And yes, I am getting a lot of comments there. Let the comments flow. Yes, I am waiting. Okay. Yes. So let me just resolve it. You are just missing one word in this question, and that is of paramount importance, because usually the test that we use is inhaled nitric oxide. And this inhaled nitric oxide test is what is called as a vasoreactivity test. And this vasoreactivity test is useful for diagnosis of pulmonary artery hypertension. But in this MCQ, he's not mentioning the word inhaled. He's rather mentioning the word exhaled nitric oxide. So you need to rule out both option number A and option number B. Guys, exhaled nitric oxide is indicative of airway inflammation. The question was based on exclusion capabilities. You had to just practice this and read the question carefully. And in this one, as I've explained, there is an airway inflammation that is present, and the disorder of airway inflammation would be bronchial asthma. So the correct one for this one would be option number C. The final summary for you guys is like this, that every time we say inhaled nitric oxide is used for diagnosis of, your answer would be given as pulmonary artery hypertension. If it says exhaled nitric oxide, though this test may not be available in most of the centers, even in good ones, we are going to call it FeNO. Ek to FeNA hota, right? Fractional excretion of sodium, that we use to differentiate between the pre-renal variety and the renal variety of acute kidney injury. So FeNA, or fractional excretion of sodium, is used for evaluation of acute kidney injury, where we can differentiate. If it is less than 1%, that would mean that we're talking about the pre-renal variety of AKI. If it is going to be more than 1%, we're going to talk about the intrinsic involvement of the parenchyma of the kidney. But since we talked about FeNO in this particular case, so that would make it the answer for this question as bronchial asthma. So two keywords here, and the learning that we learned from this is we are not going to jump into the answer to the question. Spend judicious amount of time. Try to time your reflexes at around about 30-40 seconds, and don't jump into answers for everyone, as the questions in the exam can be a little, tricky as well. Okay. So let's move on to the next one. He says, which of the following would not be correct for... Yeah, absolutely, doc. It's only the fact that it may not be available at a lot of hospitals, right? At least at district hospitals. So, okay. Which of the following would not be correct for treatment of non-ST elevation acute coronary syndrome? I mean, what we're talking about in this particular case is, if I say anything more or write anything more, the diagnosis will become obvious. So I think we are past 20-second input since I have shown this question to you. So let the questions come here as well. Okay, wait for 40 seconds. Yeah, absolutely. I gave sufficient time with my talking, and I'm giving sufficient amount of time for this question as well. He says not correct about treatment of non-ST elevation MI and unstable angina. The difference between ST and non-ST elevation MI is that ST elevation MI is a full thickness infarction, and non-ST elevation MI would be a subendocardial damage. But the more important thing is, even much more important, that non-ST elevation MI would be a platelet rich clot. It's a platelet rich clot, so I need to bust it. And let's have a look at the answers in this particular case. I think I explained this concept in even LRR as well. I have explained that in my recent sessions as well, that nowadays we do percutaneous coronary intervention for all cases of ST as well as non-ST elevation MI, because we would be in a good position to destroy the clot. Whether it's a platelet-rich clot or whether it is a fibrin-rich clot, it is more than sufficient. In case you are having problems with this, let me just solve it for you guys. You see, MI is of two varieties. It is ST and non-ST elevation MI. And the mnemonic for remembering the treatment for both of this is that you will write words like this with me. If you've not practiced this, just do it at the moment. I'm trying to solve a question under a minute. The mnemonic to be remembered is best mode. The best mode basically means that in both of them, you would be using beta blocker, that is going to be metoprolol. That will decrease the heart rate and stabilize the patient. It will decrease oxygen consumption. In both the varieties, you will be using enoxaparin for management. So enoxaparin is used in both of them. Then you're going to use statin to stabilize the atherosclerotic plaque. But now is the difference that for ST elevation MI, we can go ahead with thrombolysis if PCI facility is not available. But as far as the right-hand side is concerned, here the answer slightly changes, that we would be using not thrombolysis, but thrombolysis, because it is contraindicated. We will be using antiplatelet drugs that can be used here. These are group 2B, 3A platelet inhibitors, that is ticagrelor. And then morphine is perfectly okay. As far as oxygen is fine, that's fine. Morphine is a vagotonic drug. It will reduce the oxygen consumption of the heart. We'll be using dual antiplatelet therapy and we'll be using nitrates. So one, I've just tried to explain the only difference between the two. And in both of them, our objective is to finally do a percutaneous coronary intervention. So PCI करते हैं, eftifibatide करते हैं, exactly enoxaparin, but ranolazine is useful for management of. The correct answer is option number D. You see, I would have rather, yeah, tirofiban can be used, ticagrelor can be used. Yeah, tirofiban would be in fact a better answer in this particular case. So I can just put up there. I mean, we can be using tirofiban in this case. So the final message is, guys, tirofiban, eftifibatide, those are like IV antiplatelet drugs that I'll be using. And ranolazine is useful for management of patients of chronic stable angina. वो तो जब exercise करेगा और उसको chest pain होगा, that is where we'll be using ranolazine for management of these patients. Yeah. Ranolazine is a very good anti-anginal agent, doctor, but in emergency scenario, we will have to use the drugs as per the protocol. No, ranolazine is used as an oral drug for chronic stable angina patients. But if a person is having an MI, then we would not be using ranolazine at that particular point of time. Beta blocker contraindicated in non-stimulation MI? No, doctor. Beta blockers are contraindicated only with respect to inferior wall myocardial infarction, where there can be presence of a bradycardia, or if a person after MI is having a presence of a high-grade heart block. I mean, from the cardiovascular perspective, two absolute contraindications would be that it would help in inferior wall MI, because inferior wall MI has a vagal activation, no, so it has a bradycardia, and then heart block would also have a bradycardia. Okay, question came up, why would we be using eftifibatide? Eftifibatide as a molecule is going to be a group 2B, 3A platelet inhibitor, and that is going to help me prevent the propagation of this platelet-rich clot. Because after all, the main treatment that we use in non-ST elevation MI is enoxaparin, and along with enoxaparin, it is eftifibatide that would be used in this patient. So I think, Dr. Paul, that makes it easier for you for why do we use it. And I think best known is a good mnemonic to remember with respect to both treatment of ST and non-ST elevation MI. In both of them, we would like to go ahead and do a percutaneous coronary intervention. Okay, when there's a decompensatory, yeah, acute heart failure. So, I mean, why would we let a patient go into acute heart failure? No, if we take up in a cath lab, it's unlikely that person will go into acute heart failure. For delayed presentations, yes. Somebody mentioned regarding thrombolysis being done at 4 hours. Yeah, we'll do it. Thrombolysis in ST elevation MI can be done up to 12 hours, man. Thrombolysis in STEMI can be done up to 12 hours. It is in stroke that it can be done up to 6 hours. And in stroke, obviously, the upper limit would be about 4.5 hours. So great. Let's move on to the next question. The answer for this one would be option number D. And we can now look at an easier one. A pre-diabetic female, she has presented with the following lesion on her tummy. And he says, which of the following etiology would be causing this presentation? Okay, waiting for your answers because if I say anything else, it will become easier. So let me just utilize this time to talk about pre-diabetic scenarios where the fasting blood glucose of the patient would be hovering between about 100 to 125, and the 2-hour value of the patient will be between 140 to 199. And because the sugar is elevated, that is why they can have development of skin infections as well. And oh, great, great, doctor, great. So, I mean, good to have you online. 1 minute OPD, that's a cool thing. Good name there, right? I mean, we doctors have to see, I think, maybe 100 patients in an OPD going up to 150. So I think that's the only time that you got. And these guys are getting 40 seconds, 45 seconds for an MCQ. So anyway, okay. So because of the fact that our patient is having impaired glucose tolerance, the lesion that you can see is called as hypopaeon sign. And this hypopaeon sign would be a diagnosis of bullous empetigo. I mean, this question would be more from dermatology, but anyway, since they ask this in the exam, you are all aware that hypopaeon sign is a feature that normally to hypopaeon hum uveitis mein padhte hain na, that is anterior uveitis passing in the anterior chamber of the eye. But a lesion that is present here is hypopaeon sign, that would be bullous empetigo, and bullous empetigo is caused by Staphylococcus aureus. So the correct answer for this one would be option number D. Yes, guys. I mean, most guys would have thought between only option number B and D only. I mean, they are the two that we need to answer. I mean, Streptococcus pyogenes is what we'll be answering for routinely for scarlet fever or like impetigo, right? That is Streptococcus pyogenes or for scarlet fever. So, I mean, lymphangitis. And I mean, for MCQs of scarlet fever, MCQs of acute lymphangitis, then impetigo, where you could be having those honey crust pustules present. That is what would be present. Okay. नहीं, आज आज जो पढ़ रहे हैं ना, that would be hypopaeon आंख में होता है, लेकिन आज हम जो पढ़ रहे हैं वो hypopaeon sign पढ़ रहे हैं, and that hypopaeon sign is a feature of bullous empetigo. Okay, okay. So fine, we are sorted for this one. A pre-diabetic patient, and they can be having skin infections as well. Okay. Let's move on to the next one. Leading cause of a third nerve palsy with pupillary sparing. This is a repeat from NEET PG, so I think I can get quick answers for this one. Yes, guys. Third nerve palsy. So Staph aureus का treatment देंगे ना. If it is gonna be like CAM, I mean, if it's methicillin resistant in large number of cases, then you will not be using, I mean, cloxacillin in those circumstances. Okay, otherwise standard treatment would be cloxacillin, but sometimes it does not respond to amoxiclox. Okay, so if we are having a third nerve palsy with pupillary sparing, then in these patients, I mean, the key word is with pupillary sparing. Yeah, I think most guys got this one right, because every time we are going to have a ruptured perianeurysm or an unruptured perianeurysm, if it is present in the vicinity of PCOM, it is going to cause development of third nerve palsy with pupillary sparing. I'll just try to do a line diagram representation here. So just give me a few seconds to just represent this. Like I am trying to show here the oculomotor nerve, and in the green part, what I've tried to show is presence of fibers that would be controlling levator palpebrae superioris. And then in yellow, peripherally located, I've tried to show fibers which are going to be causing pupillary constriction. So the fibers which are present outside, the one that are in yellow, are going to cause a pupillary constriction. In contrast, the fibers in middle that are in green are going to be controlling levator palpebrae superioris. Now we're going to be having blood supply of every nerve, and you are aware that we always have microvascular disease. We always have microvascular disease in diabetes mellitus. So because of the microvascular disease in diabetes mellitus, the lesion would be occurring deep inside, and the pupillary constrictor fibers would rather be saved. And that is why we get a pupillary sparing here. I got the correct answers for this one in the chat. I think that's from the recall. But I just thought I should also mention regarding कि क्यों ऐसा होता है. So I'll just say the explanation quickly in 30 seconds. In fact, 15 seconds. We are having blood vessels which are going to be supplying every nerve per se. So because of microvascular disease and diabetes mellitus, the green wala fibers will get involved, but जो yellow wala fibers है बाहर की तरफ है वो बच जाता है, and that is why we do not get we do not get pupillary involvement in these patients. The PDF would be in the description of the video, and I'll ask my team member to put it in the group subsequently. in the description of the video, there's a link for our Telegram group where the PDF would be available subsequently. Okay. So let's focus at the next question at a hand. Meanwhile, I'll try to solve a query as well. Down and out. Yep. Yes, doctor, you're perfectly right. Non-Thingol syndrome. Okay. What is non-Thingol syndrome? Non-Thingol syndrome is an involvement of the midbrain. Uh, uh, I think I've described that in the main videos, but anyway, just give me a few seconds. I'll come back to this. This is a lesion of the midbrain, which will be involving the P1 part of the middle cerebral artery, P1 part of the posterior cerebral artery. And the highlight of this condition would be a ipsilateral third nerve palsy, obviously, because third nerve originates from the midbrain. But along with that, another structure that gets involved in this condition is the superior cerebellar peduncle. And the involvement of the superior cerebellar peduncle causes development of contralateral ataxia. Now, when I say that, I know that it will raise a lot of eyebrows with people saying, sir, cerebellum involvement causes ipsilateral involvement. Yes, guys, I agree cerebellar involvement causes ipsilateral involvement, but here the superior cerebellar peduncle involvement is occurring after decussation, which is why we get a contralateral ataxia. Why I chose to describe non-Thingol in the comment that came randomly is because in anatomy they teach that non-Thingol syndrome is third nerve palsy with an ipsilateral ataxia, but in Harrison it is given as third nerve palsy with contralateral ataxia. I'm not only giving a reference of a book, but I'm giving you the rationale behind it because the damage occurs in the SCP, the superior cerebellar peduncle, and that superior cerebellar peduncle thing is gonna be after decussation, the damage is present. That is why there is gonna be a contralateral ataxia that would be developing in these patients. So that is non-Thingol. We have three of them: Weber, non-Thingol, and Benedict syndrome. So at the moment, the data is for non-Thingol syndrome. Okay. With respect to stroke, doctor, 4.5 hours, there would be two questions. One, he will say gold standard or best ideal. Answer is 4.5 hours. If he says what is the upper limit, then the answer would be given as 6 hours. The protocol for stroke management, we'll discuss again. Like we spoke about MI in interventions in about 30 seconds. I'll do the talking about that subsequently as well. So we are going to talk about this patient who has been recently diagnosed with tuberculosis and the neck veins are prominent. There's an X-ray that's given with a very classical image that is shown here. You can notice a very significantly increased cardiothoracic ratio here as well. And he says that which of the following would be seen in this particular case. So you can notice that the cardiothoracic ratio is substantially elevated. There's a case of tuberculosis. So this tells me that this chap is having a pericardial effusion. I mean, there is a water bottle heart present in this case. I mean, why would a TB cause a CT ratio to be increased? Is primarily because this is a case of extrapulmonary TB, and that extrapulmonary TB is causing a pericardial effusion. Now, yeah, Dr. Chatterjee, as I explained to you, the answer would be given as contralateral ataxia for non-Thingol syndrome. The reference for the same would be Harrison. Okay. Pericardial effusion can increase in size and it will press on the heart, and therefore it can contribute to cardiac tamponade. Heart ko daba dega. And because of the fact that the heart would be squeezed from outside, that is the reason why you can be having presence of pulsus paradoxus. Will not have A as an answer because that's seen in hypertrophic cardiomyopathy. Answer is not B because we do not get a Kussmaul breathing in this particular case. We get Kussmaul sign, but in constrictive pericarditis, it would be pulsus paradoxus. And the technical definition of pulsus paradoxus is an inspiratory fall of blood pressure more than 10 millimeter. And that is what is happening in this case. No, we are not going to get a Kussmaul sign in this case. Kussmaul sign is not seen in cardiac tamponade. It is seen in constrictive pericarditis, and bilateral fine crepitations also can be ruled out. The correct answer for this one is option number C. That would be pulsus paradoxus, which is an inspiratory fall of blood pressure. Here you can see the difference is about 20 millimeter. Normally, the fall of inspiratory blood pressure would be less than 10, but here since the value is elevated, that is why this would be the correct answer for this question. The logic is TB से pericardial effusion हो गया, effusion से tamponade हो गया, और tamponade की वजह से, that is why pulsus paradoxus is coming in this particular case. So we are sorted for this particular question. The main thing was like we keep on reading about tamponade and constrictive pericarditis multiple times, but like this had to evaluate a bit of our skills as well from the analytical perspective. No, it is not a pericarditis. It is not a case of pericarditis. It began with a tubercular pericarditis. That's okay, but then it's gonna cause a pericardial effusion and a tamponade. So our case is having a tamponade presentation with that huge pseudo appearance of a cardiomegaly, whereas actually that's fluid outside the heart. Okay. Moving to the next one, he says indomethacin is used for management of which of the following. So those of you who are going to be sitting for combined medical services, kind of questions where you have to again select multiple options, just like in INISET. Though INISET I would suggest is much more harsher and they pick up like a lot of fine points. Here, this would be relatively easy. Okay. Yeah, absolutely. Contralateral, contralateral. Indomethacin is Claude is a combination of Benedict, right? Benedict and non-thical. Kaushal, you're right. That would be a high pressure cardiac tamponade. So we do use it for patent ductus arteriosus. Indomethacin is used for management of acute gout as well. We use it in a case of migraine as well. Do we use it for Sun CT? No, I don't think so. We don't use it for Sun CT. So can you tell me the treatment for short-lasting unilateral neurologiform headache with conjunctival injection and tearing? Okay, so I had variable responses. Indomethacin is used in patent ductus arteriosus. It's gonna shut down the prostaglandin production that will cause closure of ductus arteriosus. I mean, prostaglandins are the troublemaker here. Then acute gout, the inflammatory changes are again gonna be the crystal arthropathy caused by monosodium urate can be handled, and then is gonna be migraine. Where indomethacin can be used. Okay, I got a big query there. Yes, exactly. I think Shubham was the first one to answer for the treatment for this one. And in case you are not familiar with this, I'll just brush you off for this one. This would be short-lasting unilateral I mean, पेशेंट की कंप्लेंट होगी कि कोई ना सुई पकड़ के आंख में ऐसे पे मर रहा है जैसे somebody stabbing me with a ice pick or with a pin per se. So it's a long term. So give me a few seconds to just write on the full form. This is described in the RR component as well. Short lasting neurologiform headache with conjunctival injection and tearing. And this is going to be a trigeminal autonomic cephalgia. तीन होते हैं ना, cluster headache, paroxysmal hemicrania, and along with that, there would be like Sun CT that I have currently mentioned here. So this is conjunctival injection. That means there would be bulbar congestion. There's going to be redness of the eye. And along with that, there would be a lot of epiphora. Epiphora means watering from the eye or tearing from the eyes. That's basically, yes, paroxysmal hemicrania. We tend to use indomethacin. So the correct answer for this one is option number 3. And let me just invest about 2 minutes into describing the various types of headache that we come across. So if there's a band-like compression described in the question, and this is a young man or a woman who is stressed out in their life, they are always having office pressure, family pressure, relationship pressure, and he says that I feel like, somebody has tied a piece of cloth around my head and is tightening that piece of cloth. So that would be tension headache. If there's a deep boring retroorbital pain present, then the deep boring retroorbital pain with redness of the eye can be cluster headache. It can be paroxysmal hemicrania. It can be SUNCT. The differences between them I will be discussed in about another 30 seconds. If we talk about question about temporal headache in a geriatric age group patient, we're talking about temporal headache in a patient with geriatric age group, then it would be giant cell arteritis. Then is the pain of sinusitis, which could be maxillary or frontal sinusitis after a URTI. And then what I've tried to signify here is pulsatile headache. I mean, every time we read about throbbing headache or pulsatile headache, as they always ask, then we are always going to think in terms of migraine as a possibility. The mnemonic for migraine is pound that I'll be handling verbally. That is pulsatile headache. It's a one-day attack. It would be unilateral, nausea, and disabling in character. So I've just tried to signify the various possibilities. And then now let's just practice this quick table with respect to the differences for cluster headache versus paroxysmal hemicrania versus Sun CT. माइग्रेन का जो अटैक होता है, यू सी माइग्रेन का जो अटैक है वो वन डे इलनेस होता है कि पेशेंट पेन किलर खा के सो जाएगा, अटैक ठीक हो जाएगा. माइग्रेन का जो अटैक होता है उसका जो शॉर्टेस्ट ड्यूरेशन होता है वो 4 आवर्स होता है. जो अपर लिमिट होता है माइग्रेन के अटैक का वो 72 आवर्स होता है. And the average duration of an attack of migraine is about 24 hours. That within 24 hours, patient will, like, after taking a painkiller, there is going to be relief present. So the point is migraine is bound, pulsating, throbbing headache that would be described. But cluster headache में आप notice करोगे कि जो pain का duration है, that would be anywhere between 15 minutes to 180 minutes, that is 3 hours. If you're listening to me carefully, migraine का जो shortest duration था वो 4 घंटे था, लेकिन जो cluster headache का upper limit होता है वो 3 घंटे होता है. And there would be more than one attack per day. That's the bottom line, that in cluster headache, CH, it would be more than one attack per day. And patient will say that somebody is drilling a hole in my eye with a drill machine. So it's a retroorbital pain that would be present in this case. Contrast this with PH, that is paroxysmal hemicrania, where you will notice that the duration of pain can be anywhere between 2 to 30 minutes. So यहाँ पे याद करना है 3 घंटा, फिर अपर लिमिट याद करना है 30 मिनट अपर लिमिट. तो 4 पॉइंट हो गए. माइग्रेन का होता है 24 आवर्स एवरेज. Upper limit is 72 hours, that's okay, but average is 24 hours, 1 day illness. Cluster headache, upper limit is 3 hours, more than one attack per day. Migraine is one attack a day. Paroxysmal hemicrania can be double digits में attacks. It could be like 20, 30 attacks per day and could be going up to 30 minutes duration. And it would be a sharp stabbing, मतलब somebody is like taking a pin या ice pick, जैसे western books में लिखा होता है, they break that ice now when they're drinking whiskey or cognac or any other drink, so that ice pick says somebody is poking them on the side of the head or on the eye. And then sunset is going to be having even a worse scenario where you would be having timing given as 240 seconds. That's about 4 minutes. That's the duration of attack, and they could be like 200 attacks per day. The topic that we're discussing at the moment, the broad term that I'm teaching you is trigeminal autonomic cephalgias. In all of them, there would be redness in the eye, there would be epiphora, there would be watering from the eye, but the differentiating factors here would be the duration of pain and the number of episodes per day. And then as far as cluster headache is concerned, I've already explained the pain would be retroorbital pain, deep-seated pain behind the eye. Now comes the most critical part. The most critical part is in the exam, he's not going to ask you the diagnosis. What he's going to do is he's going to ask you the abortive treatment and the prevention part. So from the abortive treatment perspective, if he says, सबसे पहले क्या करेंगे cluster headache के लिए तो oxygen देंगे, but then they've asked in the exam, what is the drug of choice? So your answer would be sumatriptan, subcut short would be given in this case. Whereas for paroxysmal hemicrania, the main treatment would be indomethacin. And for management of sun CT, it would be intravenous lignocaine that would be given. So in this particular table, guys, just try to take a picture of this, or you can just check it out in the PDF subsequently. You are gonna remember the treatments. क्लस्टर हेडेक को क्लस्टर क्यों बोलते हैं? क्योंकि अगर आप पेशेंट को पेन डायरी मेंटेन करने के लिए बोलोगे तो आप देखोगे कि जो अटैक्स होते हैं वो सीजनल होते हैं. दे डू नॉट अकर एवरी मंथ. दे माइट बी अकरिंग लाइक स्प्रिंग सीजन, ऑटम सीजन, maybe like 8 attacks every day, and they would be lasting for something like 3 hours, and patient is going to be miserable, and then they will disappear by themselves. For prevention purposes, for cluster headache, we are going to use verapamil. Like for migraine, we will be using propranolol. In this particular case, we are going to be using verapamil. Paroxysmal hemicrania, you responds very well to indomethacin. थोड़ा gastritis वगैरह होगा तो PPI के साथ दे देना. And then not very rational, but that's the only way to go ahead with this. And then IV lignocaine for both treatment and abortive treatment, or even lamotrigine can be used for sun CT. So that was a description for TACs, that is trigeminal autonomic cephalgias. The details for these can be checked out in the rapid revision section as well. And what I've tried to explain is the rationale behind the answer to this particular question. Okay. So let's look at the least common cause of secondary headache from you guys while I'm writing the answers. This is a quick table again from the textbook that will practice primary headache and secondary headache. While I'm waiting for answers from you guys, I'll make a 2x2 table. In case you can, you have a piece of paper with you. Be my guest, just make a 2x2 table so that you can remember this with me. Okay. Sir, first we do a NS1 antigen only for diagnosis, and then subsequently we do an antibody test. Antibody test takes a while to turn positive, so you could have false negatives as well. So NS1 antigen is sufficient for diagnosis. Algorithm तो यही है ना, पहले antigen ढूंढ लो, साथ में antibody के लिए evaluation कर लो. Okay. Very good. I think I've had very good answers, except for a couple of mistakes, occasional ones. The rest of the guys have been very spot on. So how are you supposed to remember this is just remember TC for primary headache. If he says primary headache, the leading cause is tension headache. And if he says least common cause, then your answer would be cluster headache. And once you do that, then for secondary headache, it is systemic infection. This systemic infection could include things like meningitis, and then the least common cause for this would be brain tumor. So I think everybody got this fact-based question right. And in case you had any issues with this, just get these words right. TC for primary headache, and then the rest of the data can follow subsequently. The correct answer for the current question on the screen is option number D, delta. Yeah, doctor, we can be using ibuprofen as well, but the textbook first mentions indomethacin, so we'll go by textbook data first. Okay. I spoke about intravenous use of lignocaine just a little earlier for Sun CT, that is in neurology. But let's look at from the cardiovascular perspective, when are you going to be using lignocaine? Yes, guys. Okay. Yes, guys, waiting for your answers. Lignocaine is used for treatment of which of the following? So I'm having a mixed response there. Uh, चलो मैं simplify कर देता हूँ. I think all of you read about digoxin toxicity, right? I think I solved the question for you. I think everybody's read about digoxin toxicity. Have you read about a condition which is called as, if I say anything more, it will become very obvious. So I'm just going to draw it before you, right? I mean, this that I'm showing before you is normal sinus rhythm. And then after normal sinus rhythm, what I'm showing is presence of ventricular extrasystoles or premature ventricular contractions, which are occurring here, the PVCs. And because everything is happening alternatively, we are having a normal sinus rhythm, we are having a premature ventricular contraction. That means that we are talking about ventricular bigeminy. And one of the drugs that we use for management of ventricular bigeminy is going to be lignocaine. So the correct answer for this one is option number A, that is ventricular extrasystoles. I mean, instead of writing ventricular bigeminy, he described a premature ventricular contraction there. That's called as ventricular extrasystoles also. Yes, exactly, Doctor. Shubham, you got it spot on. So cluster headache, we'll be using verapamil and sumatriptan. Supraventricular tachycardias can be AFib, atrial flutter. We don't read lignocaine there. And what is AIVR, guys? Dr. Gaurav Chatterjee, just want to remark that for post-MI, current edition of Harrison suggests amiodarone over lignocaine. When I was a student, we always used to study post-MI ventricular tachycardia is lignocaine. But in the current edition of most of the books, they have mentioned both. I mean, they mentioned both MEO and they have mentioned lignocaine, but because amiodarone is given first, so we just need to take that into consideration as well. Digiband or no, first for the arrhythmia component, doctor, you need to give ventricular bigeminy. If the question says digoxin toxicity, then it is digiband. But if he's talking about ventricular bigeminy, then our answer would be given as lignocaine only. And in this question, it's a staying bigeminy. I mean, the term was ventricular extrasystole. Okay. No, Saket. Even the question was given for bradycardia in previous NEET, and in those circumstances, we'll give atropine first, and then subsequently it is digipan that would be given, because first our priority would be to increase the heart rate. Yeah, accelerated idioventricular rhythm. This accelerated idioventricular rhythm, what I wanted to hear from you is that ये कब मिलता है, तो आपका आंसर होगा कि सर जब थ्रोम्बोलाइज करते हैं, तो जब वो क्लॉट टूट जाता है, लाइक इट्स अ वेलकम साइन दैट there's a guy who's having a blockage in his left anterior descending artery, and when you are gonna thrombolize the patient, then one of the indicators of reperfusion, so now thrombolytic era is over and now it is all PCI, but just from the historical perspective, this is a reperfusion arrhythmia. It is also called as slow ventricular tachycardia. It's called as slow VT. It does not cause any hemodynamic compromise, but when do you see it? You see it after reperfusion is reestablished by doing thrombolysis. So it's a data that is given in the older times in the book, but yes, even the current edition of Harrison does talk about it. कंफ्यूजिंग किस चीज का डॉक्टर साहब समझ नहीं आया कौन सा वाला कंफ्यूजन तो वो बता दीजिए कौन सा वाला कंफ्यूजन है, फिर मैं उसको सॉल्व करता हूँ। Extended idioventricular rhythm is a welcome sign for the reperfusion. It's a welcome sign because the resolution is there. Ventricular hegemony is treated by doctor. You please check your notes again. Digoxin toxicity is corrected by giving potassium chloride to the patient. But if it's an arrhythmia, then we need to first stabilize the arrhythmia component in a patient. Yeah, lignocaine jelly in the nostrils can be used for cluster headache as well. Yeah. But it is written intravenous, na यहाँ पर, है ना? Somebody mentioned na Kaushal, I think. Okay, not Vicky Kaushal. So, Dr. Kaushal, you mentioned about lignocaine jelly. The question is about intravenous lignocaine. So let's move on to the next one. Which of the following is going to be the best intervention for preventing bleeding esophageal varices? Esophageal varices would indicate, I want you to focus on options, don't focus on my talking, because if I do more talking for the options, I'll blurt out the answer. You are having a patient who's a cirrhotic patient. The reason for this cirrhosis can be alcohol. The reason for this could be non-alcoholic fatty liver disease. And that is the reason why the person is having these varices. I mean, these are one of the two important causes. Okay. Okay. So best intervention for preventing bleeding in these patients. I am getting varied responses. Uh, okay, so the majority is doing it correct. Terlipressin and octreotide are useful for bleeding varices. I am not going to wait for the person to bleed because the question is talking about preventing the chances of bleed in a patient. And option number D, albumin octreotide, we use it for management of hepatorenal syndrome and has been asked in the previous sessions in the exam. So even if you go by exclusion, your answer would be EVL, that is endoscopic variceal ligation, is the best way for preventing bleeding from bleeding esophageal varices. In fact, whether they say what is the treatment of choice for esophageal varices or whether they say prevention part, for both of them, EVL would be the best bet. So the answer for this one, I think majority of doctors got this one correct, is option number A. Now, best is, yeah, absolutely. Best is A. And then don't get into that controversy of DOC. Depends on if you have an infusion pump, you'll be using octreotide infusion. You don't have it, you can be using terlipressin. Harrison says terlipressin is not available in America. तो अब अमेरिका में जो नहीं है तो फिर उसके लिए तो क्या ही कमेंट करेंगे. Okay. Propranolol is for prevention. Yeah, that's अगर वो मना कर देना भाई, अगर किसी पेशेंट को हेपेटिक वेन, चलो आप लोग कमेंट करो. सो बिकॉज दैट आंसर केम प्रोप्रानोल वाला, तो मैं एक्सप्लेन करता हूँ. when do you have higher chances of bleeding? I mean, in portal hypertension, hepatic venous pressure gradient more than how much would be critical to contribute to development of bleeding. I mean, what's the mathematical value? Like portal hypertension is hepatic venous pressure gradient more than 5 millimeter of mercury. So I mean, more than how much would be responsible for causing development of bleeding? Yes, guys. Yeah, hepatic venous pressure gradient or HVPG values, if they're more than 12 millimeter of mercury, they are gonna cause increased chances of GI bleeding. Exactly. 12. Utkarsh was the first one to answer for this one. Terlipressin can be used if the bleeding reoccurs. Yeah, if there's a second episode, we'll prefer going in for EVL. No, okay, let me explain. I think it will become clear. HVPG अगर 12 से ज्यादा हो तो पर्सन को ब्लीडिंग का चांसेस होता है. तो अगर हमें पता चले गया कि प्रेशर बढ़ गया है तो वी विल ट्राई टू प्रिवेंट द चांसेस ऑफ ब्लीडिंग एंड देयरफॉर वी विल टेल द पेशेंट दैट सर आप एंडोस्कोपिक वेरिसेल लाइगेशन करवा लो ताकि ब्लीडिंग ना हो जाए. वो कहता है जी अभी तो बारिश का मौसम है, अभी तो मेरे पास टाइम नहीं है, मेरी डॉटर की मैरिज है, मैं अभी नहीं करवा सकता. तो हम बोलते हैं ठीक है जी, आप दवाई खा लो, दैट इज नाटोलॉल और प्रोप्रानोलॉल व्हिच कैन बी गिवन टू दीस पेशेंट्स, एंड if they stop taking it in between, then it's gonna be a problem. So for prevention part, it is EVL and then it is drugs. Now suppose he did not, उसने सब कुछ सुना आपकी बात लेकिन उसने कुछ भी नहीं कराया and he started having vomiting of blood, he started having hematemesis. If he's gonna start having bleeding, the bleeding can contribute to hypotension. Then he will ask you, what is the first line intervention? Your answer would be massive transfusion. With massive transfusion, my goal is gonna be achieving a systolic BP of at least 90/60 because we call it permissive hypotension because I don't want it to bleed even further. I'll be putting in a gray cannula. You all know about that. I'll be not using an orange one because for that you need to have a ATLS training. We'll do a blood grouping cross matching and we'll give appropriate blood group for this patient for MT, that is massive transfusion. After MT, once the BP is a little stable, what you are going to do is start this patient on a drip of octreotide so that we can bring down the pressure in the portal vein. And by tomorrow morning, when he's fit enough, we will schedule this guy for endoscopic variceal ligation. So if they ask you first line management for bleeding varices with a shocked patient or crushing patient, it is massive transfusion. If he says drug management, it is octreotide. If he says treatment of choice for bleeding varices, it is still endoscopic variceal ligation. I'll try to summarize this and concise this in the shortest possible duration. Okay, cool. So answer is endoscopic variceal ligation, Dr. Kundu. If you have any doubts, you can refer to Harrison for this one. Okay, let's moving on. Patient presents with fever and headache for the past 2 days with multiple episodes of vomiting. He's not recognizing family members, and on examination, the chap is having nuchal rigidity with chronic signs. So meningeal irritation given, fever given, headache given. So he's trying to satisfy the triad of meningitis in this particular case as well. And I think it's a straightforward one. So टर्ली प्रेसेंट यूज कर सकते हैं ना डॉक्टर साहब, आपके हॉस्पिटल में जो भी आ रहा है सरकारी सप्लाई में इस्तेमाल करिए ना। यूएस हैरिसन में लिखा है टर्ली प्रेसेंट इज नॉट अवेलेबल इन अमेरिका, तो मैंने टर्ली प्रेसेंट नहीं लिखा यहाँ पे, जिस देश में अवेलेबल है तो वहां पे कर लेंगे भाई, है ना। तो अभी मैं तो किताब के हिसाब से मुझे टेक्स्ट बुक रेफरेंस बताना ना आपको, तो मैंने नहीं लिखा टर्ली प्रेसेंट यहाँ पे, अदरवाइज हैरिसन में लिखा होता तो मैं मेंशन कर देता। ओके, so he says कि क्या करेंगे इस particular patient के लिए। Yes guys, keep the comments flowing. I think we are having a good number of people in the chat. I want quick answers. There is a query, meningitis patient admitted to our hospital. It could be bacterial meningitis or it could be viral meningitis in this particular case. Yeah, doctor, I'll try to speak to English only. Sorry for in between, you have a tendency to just blabber sometimes in mother tongue. Okay. So guys, the answer is not lumbar puncture because patient is having papilledema. When I've taught you meningitis, I've explained to you that in any case of suspected meningitis, don't rush for treating the person by doing a lumbar puncture. If we will do lumbar puncture in a setting of papilledema, brain herniation will occur and patient can die or person can go into a respiratory arrest because they would be coning of the brain. The brainstem is going to sink towards foramen magnum. That's going to crush the respiratory center and it's going to contribute to a gross medical negligence. Please do not rush into lumbar puncture. In any case of suspected meningitis, if you read things like that there is a presence of a papilledema, in case you read that the person is not recognizing family members, it means the fact that you don't need to do a lumbar puncture right away. You need to first go ahead with a CT scan for this patient. Exactly. We need to go in for a CT scan. That is what SK mentioned very correctly. The answer for this one is A. And the mnemonic for this is punish. You can use any mnemonic, but the most important thing is, we're literally punishing the patient in case we're going ahead with lumbar puncture right away. Papilledema is a big no for a lumbar puncture. If the patient is unconscious, if there's a neurological deficit, because if it's going to talk about monoparesis, because lots of time in meningitis, there can be development of end arteritis. There could be focal damage to the blood vessels, end arteritis. And if there's going to be like end arteritis of a blood vessel, which is going to supply the motor area of the brain, then monoparesis, paraparesis can occur in an individual. Similarly, immunocompromised patient, if there's going to be presence of seizures, though the reason for seizures can be varied. It could be one of the reasons for seizures can be that a lot of patients of meningitis can have SIADH. And because of this SIADH, they can be having dangerous hyponatremia. And because of this dangerous hyponatremia, seizures can also be a presentation. So I would not like to take a risk in a guy who's having convulsion to go ahead and do this. And then any known case of stroke, mass lesion. So punish is the mnemonic for it. I think that would be an easy one. And sir, in most hospitals, first we do a non-contrast CT और उसके बाद में रेडियोलॉजिस्ट को कॉल पे ये तो बोलना है भाई IV contrast दे दे तो contrast enhancement भी हो जाएगा. So contrast enhancement is just to check for evidence of meningeal enhancement that is occurring, right? But initially, what is my objective. I want to pick up raise ICP. I want to check out dilated ventricles. And the moment I pick up dilated ventricles, I'm not going to poke the patient. That is my point. So first we do a non-contrast CT, and all you need to do is ask your radiologist to give a contrast, and you can do a contrast enhancement subsequently as well for meningeal inflammation. But considering that at the moment, I am not worried about missing out on meningitis. What I'm more worried about is evidence of raised intracranial pressure. So it would be first a CT scan in this patient. Okay, what are the findings, doctor? Ventricles would be dilated, no? If there's a raised ICP, we can measure na lateral horns, temporal horns, subca diameter can be measured, the size can be measured. So there's going to be a dilatation because of the increased pressure. So that is why we're going to do a plain CT and then just give a call to the radiologist and say, ki, by contrast, we did it. So the answer for this one would be option number A. That is the correct one. DW-MRI is useful for early identification of acute ischemic stroke. And then susceptibility weighted MRI is very good for especially hemorrhagic transformation. I mean, if he says that there is a, like, agar ek patient ko large cortical stroke ho jata hai, parietal lobe involved, temporal lobe involved, I mean, it's a big infarct, then lots of time you can be having a hemorrhagic transformation of ischemic stroke. So if he says in the exam, what test is best to pick up? I mean, obviously for bleeding, the best test is a CT scan only. But if he says specifically what is best to pick up hemorrhagic transformation of an ischemic stroke, then it is SWI, that is susceptibility weighted MRI. I'll repeat my statement again. DW-MRI is best to pick up acute ischemic stroke if there's a hemorrhagic transformation of ischemic stroke, which happens especially if it's a large stroke, large vessel occlusion, you could be having a hemorrhagic transformation, and that can be picked up by a SWI as well. Okay. Good Vibe said, how does it help in CT scan in meningitis? Doctor, it will help you identify that there's evidence of raised ICP. So give mannitol to the patient. Now, when we work in government hospital, when we don't have anything, we give empirically mannitol to the patient. But the point is, in an era of evidence-based medicine, you need to document that. The learning point from this MCQ is, any case of meningitis, if he mentions papilledema, if he mentions altered sensoria, he should basically mention punish anywhere where papilledema is the keyword. And remainings are unconsciousness, focal deficit, immunocompromised state, seizures, or any CNS known case of brain tumor, for example. So we are not going to go ahead with the lumbar puncture right away. Okay. Moving to the next one, not a feature of mitral stenosis. While you are going to be thinking about the options, I'm going to draw a line diagram here, try and show mitral stenosis before you. So there's going to be a narrowing present in the mitral valve orifice. Size is about 4 to 6 per centimeter. And this time the orifice is small. So the amount of blood that can go through this area would also be relatively lesser. Okay. Management of ischemic and hemorrhagic stroke. Doc, okay, fine. I'll try to do that towards the end, doctor. We'll try to solve these questions as well. For AIS, okay, that's too tempting an answer, Utkarsh, actually, you know that I would love to speak about it. But let me solve this question, then I'll do it for you. Okay. In any patient, not a feature, right? In any patient who's having mitral stenosis, blood को LA से LV जाने में ज़्यादा time लगेगा. First heart sound is mitral and tricuspid valve closure. First mitral valve closes, then tricuspid valve closes. If there's an obstruction present, then blood will take more time to go. If blood will take more time to go, mitral valve will close relatively later. I'll say this once again. You see, the transit of blood from LA to LV will take some fixed time depending on normal size 4 to 6. Suppose the size becomes less than 2 centimeter or 1 centimeter, then transit will take extra time. And because transit will take extra time, the mitral valve will close relatively late. And because the M1 will close relatively late, M1 and T1 gap will become less. So we will be having a narrow split S1. That is a feature. We get a loud S1 and we get a narrow split S1. Plus we'll be having a mid-diastolic murmur. We'll anyway be having a loud S1. The correct one is person would not be having a wide split second heart sound. Rather, in these patients, there would be a pulmonary artery hypertension. If pulmonary artery hypertension hoga, then the pressure is gonna force the valve from piche. It's gonna force the valve from piche, and it's gonna cause early closure of P2. You know, ये A2 होता है, ये P2 होता है, और pulmonary artery में pressure बढ़ गया, तो valve को पीछे से धक्का मारेगा. It is gonna push the valve from behind, and when it's gonna push the valve from behind, it will cause a early closure. And because of this early closure, you can see the gap will now become relatively lesser. That would be a narrow split second heart sound. So what you need to remember is that in mitral stenosis, loud S1 to hota hi hai, but he tends to go beyond a loud S1. He wants to hear about one. What I described before you is the rationale for narrow split S1. In case you missed it, I'm going to give you 15 seconds. Hack into this once again. Logic is rasta chota ho gaya. The airway, the transit area in the heart is narrow, and therefore the time taken is more, and therefore the mitral valve will close later, and therefore this gap becomes progressively reduced, the M1 and the T1 closure times. That's the rationale for narrow split first ulcer. But if there's going to be a loud P2, yes, that's one of the findings, and a narrow split S2 as well. Both are features of pulmonary artery hypertension. So I think, अच्छा नॉट नहीं देखा. ओके ओके ओके. चलो वो तो खैर गलती हो जाती है. Yes, if it is, yeah, it can be reverse split. Yes, Dr. Gopika, you perfectly right. It can be even going single and then can be going reverse split as well. So that's on. That's definitely on. It can be single. It can be reverse split as well. And eco में यार वो hockey stick आ जाएगा ना. That hockey stick finding would be present. वो बड़ा classical सा है ना. That hockey stick appearance in mitral stenosis. Opening snap is gonna become louder. Opening snap will become louder and will come closer to the second ulcer. Why there's a soft S2? Doctor, reason for, I think you asked for soft S2 in, let me just, I think it's not coming up in the chat. Okay. Yeah, it is narrow, it is single, and then it is paradoxical split. It is a reverse split. Okay, I think I'm missing one comment. And Utkarsh, your ischemic stroke is still on me, so I'll just handle that. Okay. Dr. Abdullah, can you just comment again? I could not, I think I missed it somewhere. Fine, we are sorted for this one. I'm waiting for your comments, and let's move on to merging of S2 and opening snap. Not exactly a merging, but a little closer. The gap would become less. Okay. PKS, I'll be doing physiology sessions separately. So we'll be doing pressure volume loops. I'll do it for all the valvular lesions. Very simple and straightforward. वो shape थोड़ा अंदाजा लगाना होता है, solve हो जाता है उससे. Yeah, soft S1 is with calcified mitral stenosis. Pulmonic regurgitation, doctor, blood would be leaking, no? So because the blood is leaking, therefore the force with which the valve would be closing is always going to be lesser because of the leakage of blood. So every time there's a regurgitation, the sound would be softer. I got a question. How a loud S1? So the logic for this is, doctor, I mean, that's the shortest I can explain at the moment. In mitral stenosis, there is a narrowing present. Because of this narrowing present, the pressure in the LA becomes higher. So this LA pressure, which is relatively higher, causes not more separation, not more, it cannot be more separation now because there is a narrowing present. So this higher pressure will cause a faster opening of the valve and faster closure. So the reason for loud S1 is the faster closure of the valves. It is not more separation of the valve leaflet. That cannot happen. It is faster closure that is happening. It's the speed with which the valve is closing is much more, and that faster closure becomes lesser if there is a calcification. That explains why in later stages you would be getting a soft S1 in these patients. Okay. Then he says, which of the following is best test for identifying ACTH independent Cushing syndrome? So what I'll do is subsequently we'll do it topic wise, and we'll do a bit of theory there as well. ACTH independent Cushing syndrome. So, okay, I'm getting a lot of feeds there. Okay. ACTH independent basically means that the person is having an adrenal adenoma. ACTH dependent implies that there is a pituitary adenoma, and ACTH independent implies there is an adrenal adenoma. Adrenal adenoma means that there is a tumor in the second layer of the gland. This is an autonomous tumor. This autonomous tumor will be producing very large amounts of cortisol, and therefore the values of ACTH in the body of this person will become relatively lesser. So that is why we call it ACTH independent. We call it independent because even without ACTH, it is producing one hell amount of cortisol. And what I need to do in this patient is a CT abdomen so that I can identify it. You see, the question is just twisted from what they have asked in the exam in the previous years. Whenever in the previous sessions in the exam, they have asked about ACTH dependent Cushing. And he has asked what is the initial test to be done, because we're thinking about a pituitary adenoma. So in this case, we will be doing a MRI head in this case. So just get these two facts right. For ACTH dependent Cushing syndrome, it is a MRI head. And if it's going to be ACTH independent, it basically means adrenal adenoma. I mean, every time you read these words, no, this is what should stick in your mind initially. And the remaining tests are going to be used for screening purposes. Like, yes, somebody said it rightly, A and D, midnight salivary cortisol and low dose dexamethasone. No, you don't need to remember transvaluable gradients. All you need to remember is the logic behind how that things are happening, and it will become relatively easier for you. MIBG तो उसके लिए करते हैं ना यार, pheochromocytoma के लिए. We are not talking about a pheochromocytoma, right? We are talking about and even nowadays, I think I should clarify this here. If he says what is the imaging modality of choice for a pheochromocytoma, now the imaging modality of choice for pheochromocytoma would not be a MRI and neither a MIBG. For pheochromocytoma, it would be a gallium 68 dotatate PET CT. So this is going to replace everything else in the forthcoming times. And currently, both for insulinoma and both for pheochromocytoma, this would be the imaging modality of choice. So I've covered like 1, 2, 3, at least 3 questions here. ACTH independent, that's going to be adrenal adenoma. ACTH dependent, refers to a MRI head, imaging modality for pheo, and then for insulinoma. Okay, fine. So I have good answers this one. Let's move to the next one. This I have discussed in my earlier sessions also, but I thought I should just discuss this again, lest we forget about it, because diabetic ketoacidosis is one thing that would always be asked to you. So he has himself told you it's a diabetic ketoacidosis. Yeah, Utkarsh, you can come out with your question. Patient with diabetic ketoacidosis is having thready pulses, random blood sugar is atrociously high. ABG shows all the arrows going in downward direction, which tells me that this is metabolic acidosis. So all the essentials of diagnosis of diabetic ketoacidosis are being satisfied because the sugar is elevated, there's an acidosis, there's a ketone component present. And then he says, what would you be doing in management of this patient? I'll wait for another 10 seconds for you to correct your options as well, and then we can proceed with the answer. Okay, very good. Yes, very good. Please focus on this word, thready pulses. Patient is in circulatory failure. Patient is in shock. I have repeated this question in my earlier discussions. I am again discussing it before you. I agree to the fact that if this thready pulses would not be given in the question, if the person was not in circulatory failure, then our answer will be D. Start normal saline and give insulin drip after 1 hour. That is the answer to be given in case the patient was not in circulatory failure. But here, because the patient is in circulatory failure, first I will have to make the pulses come back to normal. So I will first give bolus of saline. After that, I will give normal saline infusion for 1 hour, and then I'll be giving insulin drip for this patient. The correct answer for this one is option number A. And suppose in this MCQ, there was no mention of any severe dehydration, then your answer would be given as option number D. This is a question from last time's NEET PG. Some students, they said in their question on their screen, patient was in circulatory collapse. So if it's a circulatory collapse, we first give a bolus of saline. तब तक देंगे 20 ml per kg के repeated boluses जब तक nubbles वापस नहीं आ जाती है, till you do not get back the pulse. That's the point. And in case there is no mention of any circulatory collapse, then the answer will turn out to be D. So I hope that does justice to this particular question per se. Okay, great, Saksha. Great. Chalo, I think we are sorted for this one. Let's do another one. Saket, I don't think so. They ever ask about the rates. No, we can go on and on about it, and we can deliberate about पहले ये देंगे बाद में देंगे. वो तो सिंपल चीजें पूछता है कि भाई कि मतलब पहले क्या करोगे बाद में क्या करोगे, या इनिशियल ट्रीटमेंट आपसे पूछ रहा है, तो डोजेजेस तो नहीं पूछ रहा है. So what we do is once we discuss DK, I'll try to do that. Okay. Bolus should not be given in pediatrics. तो मेरा भी तो चाइल्ड ही था ना यार. तो बोला भाई, बोलस जो होता है, पढ़ो तो सही. बोलस जो है वो इंसुलिन का नहीं देते हैं. अभी मैं बोलस सेलाइन का दे रहा हूँ, ठीक है. बोलस इज ऑफ सेलाइन, ताकि मेरा पल्स बैक टू नॉर्मल आ जाए. तो बोलस नहीं देते हैं, मैं मानता हूँ, तभी तो बोल रहा हूँ कि भी आंसर डी होता अगर सर्कुलेटरी फेलियर नहीं होता. ओके, सो आई होप दैट मेक्स इट क्लियर. Right. Which of the following is not done in management of post-lumbar puncture headache? I think this was a recent FMG exam question and management of lumbar puncture headache as well. So Yeah, before we give insulin, we'll be checking potassium has to be checked regularly, doctor. Otherwise, because there's gonna be redistribution as well. So yeah, you will do a ABG sample, and that ABG sample will tell you the potassium also. Okay. Which of the following is not done for management of, no doctor, it's perfectly fine. Which of the following is not done for management of post-lumbar puncture headache? So lying supine will help, caffeine will help. Caffeine basically causes action on adenosine receptors in the dura mater. I mean, caffeine like paracetamol, ko pain relief tablet aati na, even that has caffeine present. PCM 1 gram with caffeine that causes relief of even migraine headache. So caffeinated drinks would help. Stool softener will help because if he's gonna lie in the bed the whole day, it's gonna cause constipation, and then if he's gonna strain in the morning, it's gonna cause more leakage of CSF from those damaged fibers in the dura mater. But we'll give liberal fluid intake in this particular case. The answer for this one is option number D. And reason I've already explained for stool softener, because if he's gonna strain, because if I do not give this, then straining will contribute to straining of any type, whether it's going to be coughing, whether it's going to be constipation, it's going to be straining while passage of stool, will increase the leakage of CSF from the tear or the rent that would be present. Yep, that was a PYQ. And well, I have a last image for you guys for today. So you can comment on these lumbar puncture needles here. So let's start with the first one. This needle is having a double-edged blade. So it will cause more duration of lumbar. I mean, that will cause more severe lumbar puncture headache. And this needle that we're discussing at the moment is called as Quincke's needle. Quincke's needle would be causing or will be inflicting substantial amount of trauma to the dura mater. So from alphabet U, you can understand that this would be a nasty needle to use. The trauma to the dura will be more as compared to the other needles which are present. So yeah, the cutting needle is Quincke's. Now, can you comment on the second needle, please? Yeah, both are, everything is going to cut the dura, no? Everything is for cutting of the dura. Can you comment on the second needle, please? Yeah. Quincke's sorted. Let's look at the next one. The second one. Exactly. So this is going to be Whitaker. Whitaker will take care of the dura mater because this is pencil tip, so it will cause less trauma. So Whitaker, like if you look at acre, right, it looks like hair. So it will cause less severity of post-lumbar puncture headache. And then you can see this one is having an oval opening. So from the oval opening, you can remember that this needle would be called as prote. The oval opening present here will make the needle alphabet help you remember that. That is oval opening, that is a Sprotte's needle. So what I try to do here is today do some mixed bag questions. I try to focus more on some central nervous system questions today because obviously some systems would always be having bias in the exam, and that is what I try to do for the same today as well. So in our subsequent discussions, I'll try to do it more topic wise, and the information for the same would be available in the Telegram group. I'll ask my team to put up the PDF in the Telegram group as well. The link for the Telegram is in the description of the video below. And okay, the motivation part is, guys, I said it in the beginning, but I'm gonna say it again. I know that you're going through the roughest patch of your career, the roller coaster, but I think you are beyond this pain. You are, I mean, a rare breed, tough guys who are gonna make this happen. So you are gonna, I mean, sustain. So rise and shine, as they say, and keep on participating in these sessions, and then you will keep on growing. I mean, our job is always to keep positive, right? Because as doctors, we just can't be sad at losing somebody. It's a uphill struggle every single day. So yes, guys, I am with you. I got your back for this roller coaster ride. So I'll keep on guiding you to my maximum capacity as I can, and I think that you are gonna do great subsequently. तो इनर्शिया नहीं रखना है। मोटिवेशन वाला तो देखो, बाहर से मोटिवेशन तो नहीं आती है, मोटिवेशन तो सेल्फ होती है, इंस्पिरेशन आती है बाहर से, बट it's just persisting man, just persist for these days, because it's very easy for anybody to get carried away because of this social media thing. But I think if you persist and keep on studying every single day, keep on learning facts, keep on realizing that okay, I made a mistake, so अगली बार नहीं करना है, right? So you just note it down, stick it up somewhere, read it again, and you are gonna do subsequently great. So Oh, great, doctor. Thank you so much for the kind words. And yeah, we will add KCL, doctor. We'll add KCL, Utkarsh, for this one. The description would be giving CMS tips, doctor. Multiple choice options are there. Try to do as much of medicine, pediatrics, and surgery as much as you can in these 2 days. And I think you'll be able to solve those questions. Doc, my schedule remains variable, so I'll inform in the Telegram group for the next class. Okay. Cerebral edema due to hepatic encephalopathy, we'll be giving mannitol, doctor. We'll be giving mannitol. Management of stroke, doc. I'll reserve it for my subsequent class. Abhi AIS में जाऊंगा ना, तो it will take another like 20-30 minutes of discussion. But that's on me. Believe me, I'll handle that. Planning for the last 10 days. Try to do one subject a day. Like I think doing one subject a day now will become possible because you can't read everything. So you can just glance through the notes as much as you can and try to do questions every day. Because I think the most important thing is you need to do questions on a regular basis. Gauri, there's a lot of content on my YouTube channel. Every time you get bored, डन विद योर स्टडीज की बस बहुत हो गया ना, तो आप उसको वीडियो लगा के बैठ जाओ, उसको 1.5-2x पे सुनो, तो आपको क्वेश्चंस करने का हैंग मिलता रहेगा. यू कीप ऑन गेटिंग अ हैंग ऑफ दैट. So thank you guys. Thank you so much for joining in this discussion, and I'll see you again. The dates would be announced very soon. Take care. God bless you.